Thank you for that very generous introduction, Anthony. Actually, I don't remember reporting any pathology for stars that I know of. And also, I wouldn't like to say that I'm an expert or the best, because this is an issue in our country, in that ocular pathology is not taught. So you can do 5 years of specialist training after your internship and residency as a doctor, and you can come out as fully fledged pathologist, and you have had no exposure to ocular oncology. And I think that's a real failure, that's a gap. And when we go to talk about gaps at the end of the day, I hope we can brainstorm that and see what we can do about it, because these are consequential groups of diseases. They're associated with morbidity and mortality. People die, and not being able to report it properly, as you'll see later, it has a real impact. Thank you also for having me here. It's great to have this interaction. Normally I'm not at the patient end of medicine. So pathology is a branch of medicine, and it deals with the essential nature of disease, especially changes in body tissues or fluids. And in our country, the standard of care for cancer is that before treatment, there has to be a tissue diagnosis. So very few oncology doctors will treat you unless they know exactly the sort of cancer that you have, because they behave so differently. And yeah, it's important. In ocular oncology, perhaps that's not always been the case, particularly in the case of plaque brachytherapy for uveal melanoma, but I think increasingly the opinion is shifting a little bit. So normally you would see your clinician, and you would have a consultation. They would make some decisions about your disease, and you may have a procedure. And whatever fluid or tissue is taken as part of that procedure goes to me, the pathologist. So I don't really directly interact with patients. What I do is I make a diagnosis. So as much as clinical staging, as Max and John have talked about, in terms of where the tumour is, how big it is, how thick it is, what's involving, what structures it's involving, there's also a pathological staging process. So the report then goes to your clinician. So I directly liaise with the people that treat you, and then they communicate that result to you, both in terms of what that means for your treatment and what that means for your prognosis. So even though I don't see you directly, when I get your tray of slides, I still know that that's a patient at the end of the day. And because I'm not in the thrust of clinical interactions and personal interactions, there is that opportunity to step back a little bit, to pull up all your previous history, to look at all your radiology, your blood tests, what you had before, and then to really think about your disease just away a little bit from the coalface. So we know that we're strong patient advocates. We know what's right for you and make sure we get the right call for your problem. And we're also very interested in quality and safety. So this is what would normally happen. You'd have a sample taken, and it goes to a laboratory, and it gets processed, and there's lots of different ways of processing samples depending on what they are. For me, the analytic phase is usually under the microscope. Even though I've had 5 years of specialist training like everyone else, at the end of my training, I can't just walk out and say, well, I'm a pathologist now, send me some cases, because pathology laboratories in this country are highly regulated, and it's mandated by law. The guidelines are set out by the MPAC, and then we also have a compliance body that comes and checks us. So there's a really strong emphasis on making sure that what you call a diagnostic test fulfills all the quality criteria of a diagnostic test. We can't just say, yeah, this is a test. Like, there's lots of tests, there's lots of research tests, but to come under a diagnostic laboratory and be called a diagnostic test, we have to meet a lot of standards. So this is an eye that was enucleated, and it's not a very big tumour, but it was quite symptomatic, and it was what the patient wanted, and this is what would come to me. Normally there's multiple levels of this, so we sample the eye quite thoroughly to make sure we're not just getting one tiny little idea of what the pathology is. This particular patient, so this is the cornea, and that's the optic nerve. This is retina, and it's come away from the back of the eye as an artefact. So this happens during our processing. And you can see here, this is the normal iris on one side, and the iris on this side is a little bit thick. Under the microscope, you'll see that this is the lens, and this is the peripheral part of the cornea. these little projections, that's part of your ciliary body, and it's continuous with iris. So this is the base of the iris. And you can see between the iris and the cornea, where the aqueous fluid normally drains through the trabecular meshwork, there are all these cells that shouldn't be there. And if you look at another section of the same eye, you can see that cells are actually crawling on the front of the iris. And on high power, you can see that the cells are really large. They're epithelioid in that they're polygonal. Oops, sorry, there's an eyeball. Don't know what that's doing there. They also have really large nuclei. They have nucleoli. And so just as there are clinical features that Max and John talked about that are high risk, these are high risk features for a melanoma. So these are epithelioid cells. We can also look at what proteins the tumours are expressing, and this happens to be BAP1 protein. So as Max mentioned, those that have a mutant BAP1, either somatic or germline, will not be making this protein. And if you look at the nuclei of this cell, which is a lymphocyte, it's red, it's making the protein. But if you look at the tumour cells, it's blue. That's just the counter stain to show us the nucleus. It's not expressing BAP1, it's not got the red. So we do multiple tests like this on the tissue itself. This is another type of uveal melanoma, and you can see this cell shape here is more spindled, so it's elongated. And this is a lower prognostic risk category on histology. And you can see when we do the BAP1, just about every single nucleus is strongly red. So that means there's a lot of BAP1 protein there, likelihood there's nothing wrong with BAP1 gene, and likelihood that it's got 2 copies of chromosome 3. So we can infer a lot just under the microscope, even down to the chromosomal level. And so when I get your eye or a sample from you, I do my best to actually get every single every single feature that's actually in the tissue that's in front of me. And I collect all of the clinical information that I have, and as well as all of these categories are features that might help us predict how your tumour is going to do. And at the very end, we use the American Joint Committees on Cancer Manual for TNM staging. So all cancers should be staged for tumour, lymph nodes and metastasis. And that helps us know how is it going to be treated, how well are you going to do. And catching cancers early improves prognosis, as both the clinicians have said. Really, I think at the end of the day, we put our diagnostic summary right at the top, and we include the molecular findings too, because for both conjunctival and uveal melanoma, that is becoming increasingly important. We know that clinicians are probably only going to read this top bit in bold, and they're really going to go into this. But this is really important documentation in terms of your tumour for later on, for research, for all sorts of reasons. And for conjunctival melanoma, the molecular testing is a little bit different. This happens to be a uveal melanoma. So when I get an eye or some tissue from uveal melanoma, I send a little bit to my colleague, Dr. Lucas, and she'll grow it in tissue culture. And this is what the uveal melanoma cells look like in culture. And then she'll extract the DNA from these cells. And what she'll do is she'll run a comparative genomic hybridization array. So that's looking at multiple parts of genes on every single chromosome you have. So that goes from chromosomes 1 to 22, and as well as the sex chromosomes. And each of these bands is an area that this test has assayed, has looked at. The raw data looks like dots, but you can make it look like a diagram, and then you can see what's happened. And here we've got a loss of chromosome 3, and we've got a gain of chromosome 8, and that's a very poor prognostic karyotype for uveal melanoma. And now we've got really compelling evidence to say we can stratify uveal melanomas into 4 groups, depending on how well they're going to do, from no risk of metastasis to pretty much definite risk of metastasis. So increasingly, this is a test that most patients want. For conjunctival melanoma, molecular testing is also available. It's different though. It's really about what therapy you're going to get. So if you have advanced stage conjunctival melanoma, we can look at what biomarkers you have, whether you get a targeted therapy or immunotherapy, and I think Anthony will talk a little bit more about that. And increasingly for patients who don't have enucleations or endoresections or exoresections, this is what a fluid aspirate looks like. So we can actually aspirate some of the tumour. We prepare it as a cytology slide, and these are melanoma cells on cytology. And we're also able to do biomarker studies on this. We're able to do molecular studies on this. So we can give you almost the same amount of information, except pathological staging, just from a fluid aspirate. What happens in my day-to-day world? Well, I generally interact with my clinicians, and after I issue my report, Max might have some more questions to ask me, and I might communicate those with him. Anthony might say, I think this patient needs to go for this trial. Can you organise some tissue to go? Or perhaps can you run a biomarker study on it? And I often have questions for them because sometimes for surgeons, especially in theatres, they don't have a lot of time to write on request forms. So I often ask for history, for orientation, for additional things that are going to help me. I don't like to practice just making calls on my own, particularly because, as I've said to you, we don't have ophthalmic pathology training in this country. So I rely on senior colleagues in the department. And in our department, we have really strict protocols. For example, for conjunctival melanocytic lesions, we show at least 2 colleagues to make sure we have a concordant diagnosis, because our clinical colleagues are relying on us to make a judgment call. Other things that I do might be input into research studies, dividing tissue for biobanking for those of you who have consented to be part of research studies, preparing material for research, and we also run some research studies in our own lab, so long as there's consent for that. And of course, we go to multidisciplinary meetings, so pathologists are always represented, where we sit down with our radiation oncologists, our surgical oncologists, our medical oncologists, our radiologists, our social workers, and other paraclinical teams, and we sit down and we get all the pieces of information together. We brainstorm what's happened to you and your disease, and we make a decision on what next. I just really want to thank you again for inviting me to be a part of this. I don't generally get the patient interface, and I really appreciate your courage in sharing your stories and your commitment to really promoting this disease and awareness of this disease, because I think it does have to be patient-driven. You are the final consumer or client, and yeah, your needs need to be met. Thank you.